All right, exciting. Beautiful. So I'd just like to welcome everyone tonight. My name's Lani Roy. I'm a social worker and psychologist, and I've ran this network for the last 3 years, and it's been an incredible journey supported by Amanda from the Mental Health Professional Network to provide a whole range of webinars, and we've covered many different topics. And tonight is a really special moment because we're presenting AMAPP, the Australian Multidisciplinary Association for Psychedelic Practitioners. And tonight we're going to cover a range of things, just our mission and our vision for AMAPP and the psychedelic ecosystem. I'm going to introduce you to the board that we've put together, which we're really proud and excited of. And Ant will take us through more of the pointy end of the policies and structures of AMAPP, which we're building with our steering group committees around risk management and code of conduct. And Matthew will also speak to governance and government relations. And we'll open up the floor to Q&A, all things TGA related. We've got Lou in the house tonight who can try and explain some of the things that are happening from a psychiatry perspective. And there'll be lots of opportunity for Q&A, and there's some other panel members in the room which we can direct some questions to around ketamine, even cannabis-assisted psychotherapy, any other things that emerge. So before we launch into all of that, really like it if we can just take a moment to drop into this space together, and you might like to even close your eyes if you feel like it. And just connecting into this incredible country that we have here in Australia, and anywhere you are from around the world as well. I know there's some people listening in from overseas. Just feeling into the traditional owners of our lands. Incredible wisdom, medicine, and dreaming that they have. Just knowing at any point that we can close our eyes or go out and connect with Australia and this country, the water bodies, the mountains, the bush. And as these medicines, rapidly move around Australia and around the world, psychedelic medicines and molecules and plants, may we really do our best to live with reciprocity and irony and balance the science and the sacred, and do these medicines proud in everything that we're doing with our research and building this ecosystem here in Australia. Thank you. Again, before we launch into discussing AMAPP, I just want to take a moment to really acknowledge some of the pioneers in this space, and there's many more people that we couldn't fit on this slide, particularly all the universities, Monash and Swinburne, but just really a big shout out and a deep gratitude to organisations such as Entheogenesis Australis, who've been working behind the scenes well before the boom for 20 years, providing education and conferences and ethnobotany, mycology knowledge, really strong community and elders in that space. The Australian Psychedelic Society, really pioneering the harm reduction space and peer support, and really excited that we have members of that community in AMAPP, which is really showing that we are multidisciplinary and that we can hold these diverse perspectives, harm reduction, mycology, community, etc. And PRISM, which is Psychedelic Research and Science, very lucky to have Martin Williams on our advisory, which we'll introduce later. But PRISM is involved in many of the trials, particularly the first psychedelic trial, which occurred at St. Vincent's Hospital with Marg and Justin in psilocybin for people who were facing death and existential issues So yeah, big thank you to Prism and their pioneering work, and Silo with their incredible scientific knowledge and pioneering education and information with neuroscience and these molecules. And just mentioning, yes, Psyche as well, Psyche Institute, who is incredible source of knowledge with ayahuasca and DMT analogues, and really pioneering research happening there with Dan and Jerome as well. And yeah, many, as I said, many organisations haven't been acknowledged in this space, but yeah, we shout out to the university organisations who are working tirelessly to get ethics approved to have these medicines here in Australia. And AMAPP really began quite organically due to the TGA announcement of psychedelics, MDMA and psilocybin being legal with a authorised prescriber from July 1st. And it's a group of us that have worked pretty hard behind the scenes to bring this vision together. And it really is a vision of a multidisciplinary approach to psychedelic medicines, where people who need these treatments get the best quality care, evidence-based practice, but through a network of multidisciplinary professionals. And we mean psychiatrists, GPs, counsellors, social workers, psychedelic practitioners, researchers, Indigenous elders, community leaders, finding a space for us all in this ecosystem and ensuring that there's multiple voices in the room and multiple skills, so that our clients can get the best out of their medicine experience. We also really passionate about the credentialing of practitioners and ensuring that they meet a certain standard. And we'll speak to that a little bit more in the Q&A. Yeah, and do you want to, I might introduce the panel members tonight, and then maybe Ant, you can just share a little bit more about the mission as well. So being the chair, would you like to introduce yourself? And
my name's Anthony. I'm a rural generalist doctor up in Far North Queensland. Happy to see you all tonight. It's a bit exciting, and I hope you enjoy and get some information and some understanding about the hard work that we've all been doing to try and get ahead of July the 1st, when this is all going to be potentially legal. Our vision really is to make it safe, to make it accountable, to make it effective. So I really look forward to your questions all tonight and giving you a bit of information about what we've been up to in the last 3 months.
Beautiful. And Lou, do you want to say hi as well? And then we'll circle back.
Yes, hi everybody. My name is Lou. I'm a psychiatrist. I work in Canberra Hospital in the crisis team. Also work in private practice with New Era Mental Health Group. I did my training in South Africa and then subsequently in England, and came to Australia about 6 years ago and got really interested in psychedelics, probably about 4 or 5 years ago, when I attended Robin Cowart-Harris's first lecture in 2019 at the Royal College Congress. And of course, lots has happened since then. So I'm happy to be on the education subcommittee. I'm the board member for that, only recently appointed. So really happy to be here and happy to see such a big turnout of people who are obviously interested in the space.
Thanks, Lou. And Lou can, with Nikolai later, can answer any ketamine-assisted psychotherapy questions as well, because he's been doing some awesome work in that space. And Matthew, do you want to introduce yourself?
Great, yeah, thanks. And just to echo what Anthony said, lovely to see you all here. I'm coming in from Adelaide today on Kaurna land. I just acknowledge any past, present and emerging leaders in the Indigenous and Torres Strait Islander communities here. My background's in lobbying and government relations. Currently I work in the policy area for primary care division in the Federal Department of Health, and previously I have a lot of background in lobbying to see cannabis exposed as a a therapeutic option for people in Australia. So it's my background. I look forward to answering any questions regarding regulation, legislation, policy around psychedelics and Pat.
Beautiful. And just finishing off, our mission there really is keeping our clients, our patients, our community at the centre of what we do, and establishing standards of care for this multidisciplinary experience. So we've worked hard to develop codes of conduct and really scaffold our organisation as a really stable platform to help support professionals so that they can do the best work that they can for clients in these altered states, which requires high level of skill and accountability and reflective practice. We really want to be unified with organisations in Australia and including, as we mentioned, people with different backgrounds, EGA, PRISM, Australian Psychedelic Society, etc. We want to have these multiple perspectives and voices in our steering committees and in our networks. Provide leadership and governance and networking, and really amplify the diversity of psychedelic practitioners. We know that obviously psychiatrists are needed for this work and clinical psychologists are needed. But what I know from working in this space is that we need psychotherapists, we need counsellors, we need paramedics, we need all this diverse experience. And we do firmly believe there is a way to have multiple perspectives in the room, valued and appreciated, and giving clients that care. And we'll speak to the credentialing framework in the Q&A as well. And yeah, just obviously really paying the deepest homage to these technologies and medicines that have been around for thousands of years, long before we have been in Australia right now in history. So it's really being conscious of these medicines from a Indigenous perspective, the lineages that are out there, but also acknowledging that we are in a modern context and we are working in clinics and labs and capitalism, and how do we as a peak body, how does AMAPP really balance that and try and get that balance in so that we provide that clinical care, but we can also do altered state work, which is held within these, peak experience states and with wisdom tradition behind us as well. So yeah, just briefly, I guess many of you know me, but my passion has been working in the field of sexual trauma for the last 15 years, and I have a real passion for supporting people in altered state work to be as safe as possible, particularly with complex trauma backgrounds. I work at the Science of Life. I'm the director there, and we run lots of student programs that support the ecosystem, different organisations in Australia. And I'm working with Susan Russell and David Castles and Claire on a body dysmorphia and psilocybin trial. Really excited about that because it is co-production and co-design. So we're actually designing the protocols with the people with body dysmorphia. And I think that's a really exciting space to look out for in psychedelic science, is where we actually come together with the people with the conditions and design those processes and protocols together. We have, and my role is the community outreach and liaison officer and on the board, and I really take that role quite seriously. Given my work in the psychedelic space in the last couple of years, really important friendships, relationships, building these long-term networks and really listening to each other, even when we don't agree, really holding this community. And that's my passion, and my hope for AMAPP is that we can do this work together and really stick together through the hard times, because there will be many challenges with this work. And as Anthony will speak to later, we want to have a no shame culture. We want to have a community where we can look after each other, critically reflect together, refer to each other, support each other, and just create this ecosystem for these medicines to stabilise here in Australia. And one more thing, really passionate about ketamine-assisted psychotherapy and cannabis-assisted psychotherapy, which I'm doing under the apprenticeship of Saj Ravi, somatic model of cannabis work, which is incredible and legal here in Australia, and a real hidden gem, I think, amongst all of these other medicines that are getting the limelight. Happy to answer some of that as well in the Q&A. And we have, the incredible Dr. Bianca Seven, and she is our psychologist, clinical psychologist with a strong Indigenous background and focus, and PhD in Indigenous psychology in Mexico. She and others have developed a credentialing framework which looks at the different tiers of psychedelic practitioners and what is needed to be accredited to do this work based on a systematic review of the literature around the world and gold standard training that's occurring. So we'll be launching that in the following weeks once it goes through our final checks and balances with our boards and advisors, but really excited to get this multidisciplinary credentialing framework out to the community and to set a standard of what we think based on clinical judgment, best practice, what's happening around the world, and also sensible care and multidisciplinary care. And we've put a lot of time and effort into that. So thanks to all those people who've helped Bianca and the credentialing team. We've got Professor David Castle as an advisor to us. Really excited to have him on board. He's done extensive advisory work and consultation with the research trials, and incredible contribution to psychiatry, particularly with body dysmorphia, eating disorders. And he's at the co-director of the Tasmania Centre for Mental Health. So we got him back from Canada just in the nick of time, which is fantastic. Ant, do you want to introduce Ernest? You know him quite well, his background.
Ernest is actually with us tonight. Welcome, Ernest. Nice to see you, mate. Ernest is a psychologist who spent at least 20 years up in the farm working in the remote Indigenous communities in the Cape, sometimes as the only psychiatrist or mental health worker when he first arrived there. He's got extensive experience in remote Indigenous health and psychiatry, so got a vast network, obviously over a lifespan of work. He's retired, but still doing work in the field of adolescent and youth mental health, and still up in the Cape. So working for non-for-profit organisations there. We're very happy to have Ernest advise us on how we can best start laying the foundation for, at the very least, remote Indigenous area work, but also obviously Indigenous psychedelic assisted therapy.
Yes. And Ernest, feel free to say hi if you want to as well. You can take the opportunity to say hi to everyone, or you can just watch your
Look, it's a great pleasure and a privilege to be on this link up and to have joined very recently in this endeavour. I'm presuming that we have on board some Indigenous clinicians in the audience tonight, and ultimately I'm sure there will be more. My particular interest is both because I've worked in that space for a long time, but also because I think that this raises some very interesting and challenging issues in relation to ethical practice with groups of people who are profoundly disadvantaged, and how we balance positive and negative rights in taking those issues forward. So I'm interested in the complexities, and I'm here to listen. Thanks very much.
Awesome, great to have you, and also acknowledging that Bianca's working with an Indigenous AMAPP group, which is establishing, their own protocols in Australia as well. So there's lots of beautiful work happening behind the scenes and in those spaces, and really hoping we can, work together. Awesome. And we've got Dr. Trail Dowie, incredible philosopher, psychotherapist. He's also the head academic and lead at ICON and supports so many psychotherapy students around Australia. And really, really fortunate to have him on board with his knowledge of altered states, of Indigenous medicines as well, and really the pointy end of philosophy, which very few people have 2 PhDs, and the amount of study and knowledge that he's acquired in his lifetime is pretty admirable. So yeah, thank you, Trail. And Melissa, you're here. Would you like to introduce yourself?
Hi, everyone. It's a great pleasure also to be an advisor to AMAPP and to have watched the birth of this at this time where we're going through a phase of transition in the psychedelic field in Australia. And my background has been in supporting the research, which has helped get us here through my role as Secretary of Psychedelic Research in Science and Medicine, or PRISM. I have a background in neuroscience, a deep contemplative practice, and I'm currently working on creating meditation adventures or I guess immersive journeys that can support both psychedelic assisted therapy, ketamine therapy, or just psychotherapy on their own through virtual reality. And what I'm excited to see AMAPP's role in the community be is a nexus between research, between clinicians, between advocacy for the regulations for therapy to be rolled out in a way which combines and synthesizes knowledge from research, from Western psychology, from traditional practices, and evolve the clinical delivery in Australia.
Yay. I get very excited about all the things Melissa does because it's such a diverse skill set, and yeah, very lucky to have you on board, Melissa. Thank you.
Thank you, Lani.
And just a couple
Lucky to have you.
We're a bit biased because we're friends, so yeah, and very, very, very excited to have these wonderful people, Professor Susan Russell, and yeah, there's the amount of work that she's doing in the space at the moment with Martin Williams as well, in major depression trials, body dysmorphic trial that I'm working on, and many other trials. She's a powerhouse of sensible science and really, really knowledgeable from a neuroscience perspective, neuropsychiatry, and yeah, feeling very fortunate to have her on board. And Martin Williams, who is the I'm just trying to think, Melissa, you're the Secretary of Prison. He's the Director of Psychedelic.
Executive Director.
Executive Director, yeah. And working very closely at Swinburne on the major trials, and been a early pioneer in the space and in supporting, obviously, this St. Vincent's trial as well for psilocybin. And we have Diana Korivar, a psychiatrist that's worked on the clinical trials through Monash, and also has a strong background in attachment trauma and I guess mother-baby care, but really has a really strong insight into attachment, and that's key in everything we do with psychedelics, and also this organization and these medicines is attachment-based care, trauma-informed care. And Nicola, are you here? Do you want to introduce yourself? He was planning on being here tonight, so I'll have to make sure he's okay in the break. But yeah, he's been around for a long time in the addiction space, and particularly in ketamine-assisted psychotherapy, and has been a real pioneer in getting that up and running in Brisbane, and providing fantastic consultation in the addiction space. But yeah, I guess before we move on, when AMAPP was created, and my role in the community outreach and liaison, it's really to ensure that our board and our advisors are real people that we're in real relationship with, that we're working with, that we're listening to, as well as our members and our steering committee. And Ant can talk about how AMAPP has been structured and the codes of conduct and the policies. But yeah, lastly, just one more thank you to our advisors. We don't take this lightly. People's reputations, people's credentials, and yeah, it's a really privileged position to be working with this talent and these people in Australia. All right, Ant, do you want to speak a little bit about the structure of AMAPP and the nuts and bolts of it?
Yeah, happy to. Okay, so this all started out in February when the TGA surprised really all of us with their change in the scheduling of the drugs, and it became quite obvious that nobody was prepared for this, but at least people who had some sort of training or understanding of psychedelic assisted therapy and the medicines themselves were probably best placed to try and get this done safely and effectively and also practically, without running around like headless chooks because we didn't know anything and being scared of a medicine that we didn't understand. We thought we're probably best based to try and provide some guidelines around this. So AMAPP sort of organically came into being really from the ground up, from a bunch of people with psychedelic knowledge who'd been on chat groups for a while, and it's sort of built up from there. We've got kind of an advantage. Before I go into what our sort of guiding frameworks were, we've got a kind of advantage that was brought to my attention the other day. I was speaking to a sort of sister organization in the United States who came into being and had a huge amount of funding straight away. They just got this massive amount of funding. She wouldn't tell me how. But they were plonked down into the space and immediately had credibility problems. So the community immediately looked at them and go, well, where did you come from? Why do you have all this presence? Where's your credibility? And while I would have loved for us to have a little bit more funding early on to get things done a little quicker, what I've realized is that we have built a framework of credibility by our vision and our mission, and then by backing up that vision and mission with some credible policies. And so we're actually been attracting people that I'm very humbled to have on our advisory and on our board, because of not because of our presence, which wasn't huge and isn't still huge, but because of what we stand for and what we have put forward in a considered way as a way to move these medicines into the public space safely, effectively, and accountably. So I'll go into how we sort of thought about this from the ground up. And the three pillars that we really wanted from the clinical side of things was to have a code of conduct, a clinical governance policy, and a credentialing policy. And we realized that the credentialing policy was going to be one of the most contentious ones, but it needs to be informed and it needs to be transparent, and it needs to stand up to scrutiny and to be reproducible. And it needs to provide therapists that actually do have the skill set and the understandings that are needed to keep people safe in this therapy. So the code of conduct was a fairly straightforward code of conduct. Matthew did a lot of work on this, and it essentially goes through every aspect of ethics and conduct, both with patients, conduct with the wider community, conduct with within the organization. Very importantly, how we deal with each other is going to be how this organization thrives and survives. How we treat each other is going to be how this organization, where this organization's strength is. It's not going to be in how much money we manage to attract and how many therapists we have. It's really going to be how we treat each other. So the code of conduct is on our website. Everybody's free to peruse it. I'm not going to go through all the different aspects of it, but it's around client safety. It's around confidentiality, our own professional development, which is, we have to come up with, and we started working on what does professional development mean in the psychedelic space? What does continuing medical education mean, or continuing professional development mean in the psychedelic therapist space? We come from such multidisciplinary backgrounds, which is just a fantastic thing to work with. We've all worked within our own siloed medical backgrounds, doctors, psychologists, psychiatrists, and a lot of us really are not used to this this multidisciplinary community, and the different aspects that everyone brings to this is just truly wonderful. So that's the code of conduct, and we've made this code of conduct strict. We've made it all encompassing, and we've made it as clear as possible. And we will hold our credentialed therapists to this code of conduct, and ourselves to this code of conduct. The second pillar was clinical governance. This was a tough one. I come from a medical background where clinical governance is very much in the fore. And so what we decided to adopt was a clinical governance policy that I grew up with when I moved to Queensland, and Queensland Health adopted it after, I think, the Fitzgerald inquiry with the Bundaberg issues and all that. And it's brought a little bit from the airlines who brought a code of conduct and of investigating incidents that relied on the idea that a trained professional who's got patients or passenger safety at heart isn't going to make a mistake on purpose. And they're going to make a mistake because they're human and they sit within environments that allow them to make a mistake rather than help to prevent them making mistakes. And that leads into a very much no blame policy when investigating mistakes. So somebody makes a mistake, it's not because that person meant to. And I'm not talking about criminality. Criminality and criminal negligence are a complete different story. They refer to the authorities, and there's no question about that. But mistakes, which we all make because we are human, and there is no human that doesn't make mistakes. But we can put systems in place to try and prevent the mistakes. So the clinical governance policy talks about a no-blame culture where a mistake is investigated and the systems around why that mistake was allowed to be made are more important than the person who made the mistake. And it's got a number of different tiers. It's quite structured. It's and it tries to put in place preventative issues. But it starts with recognizing that people make mistakes, and then it goes to the next stage. Well, in psychedelic therapy specifically, where are the mistakes likely to come? What do we know? We don't know much because there hasn't been a world history of psychedelic use that we have access to. That's categorized mistakes and where they come from. So we had to think about, the areas that mistakes are likely to come. The obvious one is a lot of mental health workers are unfamiliar with using touch. The consent around touch is problematic. So we need to look at those sorts of things. But we need to look at patient selection. We know that patient selection is potentially a big cause of an unexpected adverse outcome. We need to look at therapist training, which is obviously what our credentialing policy is about. But we need to look at supervision as well. Those were some of the things in the clinical governance policy and risk management and risk prevention. And the clinical governance policy, it's called a human error and patient safety policy. And it's got a number of ways to investigate any adverse outcomes and incidents. But before we even get to that, we really looked at what happened with MAPS and that cover story that blew up about a really adverse outcome for a particular woman who was involved in the MAPS trials. And what became apparent is that MAPS had trained their therapists. They told them how to behave. They had a code of conduct. They were recording all their sessions. But what they weren't doing is they weren't looking for mistakes. They weren't expecting their therapist to make mistakes or to go slightly off the reservation. And so when this was brought up, they were caught by surprise because they had been looking at the videos as a routine and they hadn't been expecting mistakes to happen. And that's where we really want to up our game here. So our clinical governance policy, with all the structures that we put in place, is a proactive clinical governance policy. We're training the therapist. Well, we're not training the therapists. We're credentialing what we feel are trained therapists. We're putting as many systems in place as we can to prevent mistakes, but we're looking for the mistakes. So in that vein, we're going to ask all our members to record sessions with obviously consent of clients. Now, in the trials, almost all sessions are recorded. It's not something new. In mental health supervision, recorded sessions are not something new either. In the early stages, in the first year or so, we've got to make this work really well. We can't be pushing the edge of the envelope when it comes to protocols or when it comes to patient selection. We need to do this right because the community is not going to accept mistakes in a medicine that's been so stigmatized for so long. And to that end, we want all our therapists to record the sessions, but also, to do audits. There's not something that people are necessarily used to, but there's going to be auditing, and the audits should be done in a couple of ways. So any unexpected outcome, you've had an unexpected good outcome, you've had an unexpected bad outcome, do an audit. AMAPP's going to provide templates for those, and you run through what you did. Maybe we can work out why you had a good or bad outcome. But those audits, sorry, that's the first thing, is unexpected outcomes, good or bad. And the second way we want people to audit is randomly. So we're going to ask our therapists to do random audits. Now, it's a bit hard to know whether to do that in frequency or number, and it depends on what the numbers are and how frequently people are seeing patients. But if you're a single person practice, you might get together with the guy up the road or the lady up the road and do audits together. Do run through a couple of cases that were unusual and run through just a couple of random cases. Talk about them. So case discussions amongst yourselves. If you're in a bigger organization, then it's a more formalized process. But we'd like those audits to be uploaded to a secure database. And this is where a really potentially world-leading collection of data can occur. So we'd like all the therapy that's done with AMAPP-trained therapists, audits of those therapies to be uploaded to a database. And ultimately, we want to have a wide database of community-based therapy on a national scale, which has never been done before. The data from that de-identified will be used for quality improvement for our own therapists. It can be used for research from anybody who wants access to do research. And we'll ultimately set up an advisory around that database to try and facilitate research, make sure that people aren't doubling up on research. But there's going to be no restriction of access to researchers, credible researchers to that database. So that's our hope, and that's really how we hope to, and how we designed the system to be as credible and reassuring as possible. The next step of the clinical governance policy really comes to the adverse outcome. So if there has been an adverse outcome, what do we do? In psychotherapy, that's also a difficult thing to quantify. What's an adverse outcome? A patient comes in, has been told that he or she's going to be cured from their depression, and they're not. To them, that's a hell of an adverse outcome. And there's going to be complaints. There's going to be people who are going, I've been ripped off. And part of that management starts now, and it starts with all of us. Been a lot of hype about psychedelic medicines up to now to try and get it over the line. All of our jobs now is to de-escalate that hype, is to bring credible, realistic expectations to all our clients that come to us from now on. All right. And to actively address unrealistic hype in the community. And that's really all of our jobs. And that's part of our preparation starting right now with clients that we don't even know exist, is de-escalating that hype and putting realistic, pragmatic expectations forward for the community at large. But let's say there's an adverse outcome that's easy to quantify. Let's say touch. An inappropriate touch occurred, not malicious, just occurred because the consent around it was maybe slightly blurred, or the client changed their mind about consent halfway through, and the therapist was unsure what to do. But let's take that as an example. We then move into a phase of what's called open disclosure. There's many ways you can address a client or a consumer that comes to you with a story of an adverse outcome. What open disclosure does is it says we are completely open and transparent about what's just happened. So we will have a team. It'll be a senior clinician, maybe the clinician involved, and a safety officer. I would hope that AMAPP will have the resources to have a permanent safety officer on staff. They're going to be the person that might review those audits randomly as they're uploaded, but there'll be a resource person that can be provided to therapists in the setting of an adverse outcome. So it's those maybe three people: senior clinician involved, and a patient safety officer, and the client with their support person. And it's a sit-down meeting where harm is acknowledged, okay, where adverse outcomes are acknowledged. We are sorry that this happened. Straight up, we are sorry that this happened. How was this for you? It's a lot of listening. How did this land for you? What would you like to see happen now? What we're going to do is we're going to go and do an investigation and to work out exactly what happened and why it could happen. What do you feel is the outcome that you would like from this? Okay. This is the contact person who's going to have all the details of the investigation as it goes forward, whether that's the AMAPP safety officer, whether it's the safety officer from the organization that gave the therapy, if it's a big enough organization to have that. Here's a phone number. More importantly, here's the phone numbers of all the regulatory organizations that might be people that you would like to talk to. That would be Health Consumer Complaints Commission, consumer advocates, whatever those numbers are. Here are the numbers. Here's a list of the numbers that you can call if you don't like the way this is going, and if you don't like what's the outcomes that have happened here. This is the person that will tell you how the investigation is progressing, and we will bring you in at any time that you want to talk about it. But certainly after the investigation, we'll bring you in and be as transparent as we possibly can about that. In a big organization like Queensland Health would offer financial compensation, not compensation for harm or stuff, but if you've missed work, how can we help you with that? If you need ongoing treatment, how can we give you that for free? If the harm that's occurred here has meant that you need extra therapy, how can we do that for free? Now, obviously, resources are an issue. I'm really hoping that we have the resources to be able to provide those sorts of outcomes. Okay, so that's very briefly human error and patient safety and open disclosure. That's what we're bringing here. We're bringing it's not over the top, but it's unusual for a lot of people to see this level of proactive clinical governance. Alrighty. So code of conduct, clinical governance. The third pillar was really the credentialing. Now, credentialing policies pretty much finalized. We just haven't got together as a board and ratified it and made sure there were any other things that need to be tweaked with it. This is a very difficult and very well done policy document. It's taken advice from international areas. It's looked at all the courses available in Australia and the world and sort of tried to have a look at what they've got in common and what they offer. And AMAPP is not endorsing any course. It's also not disendorsing any course that's been done, but it's got criteria that are going to have to be met to meet credentialing. So many hours of learning, so many subjects covered, things like pharmacology, ethnobotany, indigenous medicines, obviously neuropsych, psychotherapy, all those sorts of things.
Can I jump in there?
Yeah, go for it.
Sorry if people can't hear me. Let me know if I'm too quiet. So I guess the vision for the credentialing framework is that we have an accredited register of multidisciplinary professionals that trials or psychiatrists can search and go to and know that there is a certain standard of training, of credentialing and accountability, and that there's also a ongoing professional development arm, which Lou and others will be developing in the education team, so that there's professional development, ongoing critical reflection, and certain tiers of training. So a provisional therapist that's still learning and hasn't necessarily done enough dosing yet, that they're needing a certain amount of criteria to ensure that they meet those credentialing standards to become fully accredited. And then, of course, an AMAPP supervisor as well that has done the trial work, has done the dosing work, supervised people, etc. So yes, we will release that in due course, but there's been a lot of work that's gone into what is the structure and the ecosystem that's really needed to scaffold and hold these medicines and support clinicians to get to that level of confidence and skill with the mentoring and the training, best practice training that's out there. So yeah, very exciting, but lots of hard work behind the scenes. Anything else you want to add?
So the credentialing, as we said, is going to provide us with a database of therapists that are credentialed. And that's really important for this journey. And it means that clinicians, researchers, and anyone can come to a database of people, and search by state or postcode, and see where there are therapists and facilitators that they can work with, and trust that the training is adequate. So look, those are three arms of the clinical side. We're going to be offering a lot more stuff, continuing education, community, just so important for all our practitioners. These therapies, if anyone's ever sat with someone for 6 hours or 8 hours, just holding space, it's a very draining and a very intense therapy to give, and support is and community is what we offer at AMAPP as well, along with all the other side things like education. And at the moment, we've put together a slide presentation for GPs. So any of our members can go out to their local GP group. We've got a lot of GP members, and give them a little bit of education about that. It's going to be education towards prescribers, helping them get credentialed to prescribe, education for public brochures that people can take away from the website or can read off the website. And all of this, our focus on all of this is client outcomes and de-escalating hype, realistic outcome expectations. So de-escalating some of those hyped expectations in the community. So look, I've got not much more to say about all that. I don't know whether Matt or any other folk want to say something, or we can just open it up to questions.
I might stop sharing the slides because I feel like we can probably just speak to it. And Lou, from a psychiatrist's perspective, do you want to share a little bit about what you're observing and key take-home messages at this point?
Yeah, for sure. So I think it's worth mentioning that the Royal College of Psychiatrists was somewhat taken aback by the TGA decision, as were most of the population. So they have done webinars to educate psychiatrists on their platforms. The one that went out in March of 2023 was attended by about 500 psychiatrists who could access that education. And essentially they gave the college position and their intention about how to support psychiatrists. And it's particularly important for this conversation because, as you're probably aware, accessing these medicines is only going to be through a psychiatrist who is an approved prescriber. So of course the TGA decision, for those of you folk who aren't aware of it, was to reschedule MDMA for PTSD and psilocybin for treatment-resistant depression from the poison standard, which was standard 9, Schedule 9, to Schedule 8 as a controlled substance. They're only rescheduled to the Schedule 8 scheduling for those two narrow conditions. So any other indications, it's actually still illegal to prescribe, and you cannot prescribe those medications for things like, I don't know, end-of-life anxiety and the like. And as I said, the prescribing pathway is psychiatrist only, and the way for a psychiatrist who's interested in becoming an approved prescriber is to go through a process that involves the Human Research Ethics Committees. Now these committees, there are probably about 500 of them across Australia. They're usually situated in metropolitan areas, but also major hospitals. And the idea is that the psychiatrist who's interested will seek approval from a Human Research Ethics Committee and then subsequently obtain authorization by the TGA under the so-called authorized prescriber scheme to actually prescribe this medication on a case-by-case basis. So the Human Research Ethics Committees are used to passing ethical approval for research trials. It's fair to say that of the 500 across the country, there will not be many of them that have the experience in giving approval for a psychedelic pathway unless they've been involved in a randomized controlled trial and have approved ethics for trial practice. But essentially, the requirements will include, and as Anthony has already touched on, things like clinical justifications. In other words, does the patient meet the criteria for PTSD or a treatment-resistant depression? Again, remembering that there's no globally accepted definition of what a treatment-resistant depression actually is. And again, they would want to be assured that the right patients have been included or excluded from the submission to the HREC. So the sorts of patients who would be excluded would be people with a psychosis, for example, or a first-degree relative with a psychosis, or a previous history of, for example, a bipolar disorder. And then they would want to be assured that the setting for the medicine session is appropriate, because, of course, this is very different to any other kind of medicine that we prescribe in psychiatry. Most people who work in the psychedelic space understand the importance of the setting, so they would want to be assured that it would as closely approximate the research evidence base for what the sort of room should look like and how many staff should be there. And again, AMAPP is going to be aligning a lot of its standards to the research evidence, because that is going to confer the best clinical governance and safety pathways for patients. They will be also very interested in seeing how the environment will be controlled. What safety protocols do you have in place? Do you know how to access crisis services or paramedics if something goes wrong? Do you have emergency equipment like CPR equipment if somebody has a too rapid heart rate and has a myocardial infarction or something, which can happen? And then how will this treatment be combined with psychotherapy? What sort of psychotherapy? And once again, we know that there is no explicit statement about the sorts of psychotherapies that work best with psychedelics, because we simply don't have the answers to all of that. We know that there are trials in Yale that have used acceptance and commitment therapy in influenced designs. You've got obviously the MAPS designs with Grobian influenced psychotherapies. At Imperial, they use ACT as well, I think, or various other models. So the HREC will want to be assured that the psychotherapy meets muster, and at the very least is obviously trauma informed. And then again, have you got adequate consenting protocols? Have patients or clients been given informed consent, and have you gone through and are you able to evidence that you've educated them about non-ordinary states and what sorts of material may come up? And and again, speaking to Anthony's points about, we're not saying this is a panacea for everything, it's going to cure everything, and by definition, you're having patients coming in who are very complex. They've already gone through various algorithms of treatments for PTSD and depression. So one might imagine the risks associated with treating these patients are going to be a lot more significantly potentially than first-line treatments for people with mild presentations. And then again, how are you going to store the medicine? It's a Schedule 8 medication, all the protocols around medication storage, and you can't, go to a compounding pharmacist and get them to produce MDMA or psilocybin. You certainly can't be offering the mushrooms that you've been growing in your backyard. This has to be, medicinal grade pharmaceutical medication that comes from, recognized distributors. And again, it speaks to being able to do everything within a tight legal framework. And again, the differences for different states are going to be different because, of course, all of the legislation around poison standards and medicines have to be aligned after the 1st of July. So again, it's just speaking about the governancing that is required of all of us. Just some context with the college. Our college made submissions to the TGA and were not in support of the rescheduling of these medicines, both in March of 2020 and May of 2022. So they did produce a clinical memorandum, which is on the college website going back to July 2022. And in that, they did not support the rescheduling. But of course, subsequent to that, the college has had to rethink its memorandum. And one of the major outputs from its steering committee that they've just established is to amend the clinical memorandum. And that'll probably be delivered by the college steering group on psychedelic assisted therapy by July, because of course, our psychiatrists need to be given guidance on what to do. So it's fair to say that the TGA controls have been, I suppose, allow a much narrower door for people to access these sorts of treatments than what might have been hoped for by folk who are advocating to the TGA. And personally, I am very happy that the governancing and the narrow door is in place, because we know how things went way back in the 60s when things got too big and too hyped, and we got into trouble. So from the college perspective, they've formed a steering group. The terms of reference were stipulated and made public on the 8th of March. They had expressions of interest for attendance on that steering group. Apparently, there were huge numbers of people who wanted to get onto that steering group, and then they are probably going to be meeting monthly, maybe even more frequently than that, to come up with the guidelines, which are going to be the main guidelines that psychiatrists will be looking for. The membership of the steering committee includes the chair, who's Professor Richard Harvey. He is a telehealth psychiatrist. He's, I think, originally trained in England and then came to Australia. He's got a huge number of publications. He's an academic. I think he's a really good chair. You've got people like Professor Colleen Liu, who is involved in neuromodulation, Professor David Castle. I think we also have Dr. Nigel Strauss. So they've got quite a varied group of people. Not all of them have been involved in psychedelic therapies, but a lot of them have been involved in novel treatments and experimental treatments and have a research background. So I'm hopeful that the guidance that comes out to psychiatrists will be measured and balanced. It's fair to say that what the college is doing is liaising tightly with the TGA. They, like us, are engaging with the media and public, and they also have quite wide stakeholder engagement. What they will probably be doing, and this speaks to my earlier point about these 500 HRECs not necessarily having had experience in psychedelics before, is they will provide guidance to the different HRECs. So one can expect the same sorts of standards emerging across the country. The college I'm referring to is the Royal Australian and New Zealand College of Psychiatrists. Sorry, I've been talking at length about something that some people don't know about, but I suppose I'm giving the perspective of a psychiatrist because of, as I said earlier, the very narrow path which requires an approved prescriber who can only be a psychiatrist, so that you understand what the psychiatrists are hearing about. Essentially, the college, much like us, is advocating for a cautious approach. They also want us to build on a research evidence base. Their view is that in community use of these medicines under these tight conditions is an opportunity for real-world patient outcome data to be collected. It's almost like a phase 4 trial in a way. And we want to build on the evidence base and avoid unintended consequences. So they're also advocating for, I know that we would like to develop a registry in AMAPP, but they're advocating for an independent national clinical registry to be set up, and they're looking for somebody to fund that. I suppose the issues that they are raising is that they expect significant difficulties for people to access these treatments outside of metropolitan areas, just because there are not that many psychiatrists who are trained in this, and it might amplify existing workforce shortages. And we know that already accessing any kind of psychotherapy is currently insufficient. So I'll just leave it at that. That gives you the perspective from the psychiatrists.
Just very briefly before we move to the Q&A, Ant, do you want to just mention a little bit about the actual the constitution, how AMAPP is established as an organisation, or what it's moving towards?
Yeah, sure. I see there's a question here from Livy. I'll just address first. How do you see the roles of psychiatrists, counsellors, psychologists evolving continuity from prep or dose integration, or psychiatrist on site all the time. I think a lot of that stuff is yet to be advised. I think my personal feeling on it is that a psychiatrist should not be dosing the medicine if they're not trained as a psychedelic therapist. They shouldn't be in the room on the day. I'm hoping that any psychiatrists that want to be in the room and are trained psychedelic therapists would do that. But I think it's difficult for the business model of most psychiatrists to spend the 20 hours in total needed with a client. So what I think will happen is that psychiatrists will assess the client, make sure that they're fit for therapy. The GP will have given a medical handover about medication issues. The client will then be referred to therapists if they weren't already with psychedelic therapy, trained therapists, and the script will be given by the psychiatrist. It's actually an essayed medicine, so the pharmacist can store it. And anybody can pick up that script. So, for example, if you were concerned that about giving the client the script, the therapist who's giving the treatment could actually go to the chemist and pick up the treatment. Then the client gets treated by the therapy team, whether that is the referring psychiatrist, if he's therapy trained or not. For the duration of the therapy, we know that's prep, medicine integration can be weeks to months, and then handed back to their original therapy team or continue on with the therapist, whatever is most appropriate there. I'll just quickly talk about our constitution. This was a credible constitution set up with our legal team, and we're set up as a not-for-profit and charity organisation. The basis of our charitable status is providing education, promoting healthcare, and providing public awareness and healthcare. What we hope to do with our philanthropic donations is to allow a large percentage of clients to be treated from philanthropic donations. So I'd really like to see most of our clients who, as we know, the ones that need this therapy are overrepresented, overrepresentedly unable to afford it. So I would like to see donations made, and we've got a couple of ideas about how we can do this. Donations made so that therapy can be provided at a very reduced or free cost. I'd like some of our therapists to provide their time pro bono for some of this work. And we really hope that we can attract people who want to actually progress this medicine in a very concrete way, to give some of their hard-earned money to allow that to happen. At the moment, it's all volunteer work, and I imagine that will continue into the future.
And I might actually just ask if anyone wants to voice questions. Would be great to connect with people. So feel free, if anyone's written a question and actually would like to speak to it, go for it.
If I could just go to, I guess, the second part of Libby's question, will there be public funding? Depending on whether or not some of these medicines end up being endorsed on the pharmaceutical benefit scheme, there will be maybe access to those medicines. But I know with large Medicare reforms that have occurred at a federal level, we've seen the allowance for, I believe, an item code E, which will allow for up to and beyond 60-minute sessions to be subsidised in some capacity. Now, I'm not sure what the limits of those particular sessions will be and whether they can be applied to psychiatrists prescribing these Schedule 8s, but definitely there is a lot of interest about supporting longer multidisciplinary care options when it comes to patients and the quality of life outcomes that they're now seeing.
I just want to respond to what I've heard and just say I think it's great that thought has been given to those that can't afford it. I think that's really important. And also good to hear that there might be, some public funding. I guess my concern is that, therapists aren't necessarily the highest paid people in the world. I know from my understanding and experience. And it might be, I think working on a sliding scale is great, but it might be unrealistic for us to pick up, the vast need out there. So more public funding, I think, is what I'd like to, be seeing evolve, within the lobbying space.
And Libby, what we'd like to see at AMAPP is through a credentialing program that we can actually mentor and supervise, provisionary therapists. So part of their training, that there is some capacity for them to do pro bono work, but they're getting like really supported through, you know, mentors and leaders in the space. So I agree, we can't have people doing unpaid work and being devalued in this space, and you know, psychiatrists being paid well. They deserve to be paid well, but there is a, you know, severe, you know, discrepancy there. But what I'm hoping is that we create pathways where students, you know, really excited to be in the room, can give up their time, but be mentored and supported. And also acknowledging there is some capacity for NDIS. I know I've done some ketamine work, and some of my clients have managed within their plan to get, you know, they're not going to get the 8 hours paid typically, but there is, you know, there are some line items for room hire under capacity building for the prep dose and into the preparation and integration to be covered. So it really depends on your plan manager and or self-managed package as well. So I think we have to think outside the box as well with the costs, and hopefully eventually one day insurance agencies as well as Veterans Affairs. You know, the amount of money that is spent on treatments that don't really work for veterans. I feel, you know, we're connected to a lot of veteran people, and we feel that it will be cheap for them comparatively to other treatments that they're investing money in and not getting a whole lot of return from. So I'm optimistic. We just got to get our thinking caps on. Anyone else want to launch in there? Question?
I'm just curious. I'm just curious about the requirements then around administering Schedule 8 drugs. Considering the challenges around psychedelic treatment becoming, you know, accepted in the mainstream already, it would seem to me that there'll be quite strict requirements around who is able to administer the Schedule 8 drugs. So my understanding is that would require a psychiatrist or a GP or a nurse to be present and to be the administrator. That other disciplines it wouldn't be within their scope of practice to be administering that. So I'm just wondering what thoughts are around that. And I'll hand it back to you on that note.
I can speak to that if you like, Erica. The issue about S8s is an interesting one. And I'll give you the example that I think I wrote possibly to you in the chat. A client can go to a doctor and get morphine prescribed. Morphine's an S8 drug. They can then go home with that script. They can give their script to any family member or anyone to go to the pharmacy, pick up that script and give it to them. They can then take that medicine without any supervision at all. So that is where I expect, I don't expect it to be any different for this S8. So it won't need a medical practitioner. It won't need an RN on site to give those medicines. However, one of the things that AMAPP is going to put in as a requirement for any clinic that gives the medicine, and this again is an over-the-top requirement to reassure people, is that there should be a medical doctor aware of the treatment and on call. Now, there are plenty of GPs who've gone through one or another form of PAT training spread all around the country. I'm hoping that with a little bit of education from our members to the GP groups in the areas that they live, that GPs will have a basic understanding of some of the issues that they might be called about. It's incredibly rare in the trial literature for any client to need any medical intervention. That means, a physical intervention because of physical illness, or a psychoactive drug to counteract a psychological reaction that the client's having. If you do this right, and you choose the right clients, and you do it in the right place with the right people, and you take your time, it's incredibly rare for that to happen. But we're going to make that a requirement, that there is a doctor aware of the treatment and on call.
Beautiful. And whoever just asked that VR question, our Psychedelic extraordinaire Melissa's just left, but there's Psychedelics that are pioneering this space, and also Ignosis, which is Prash is a psychiatrist, and Agnieszka doing incredible work with VR and looking at how to scaffold client experiences so that they can enter the VR after their psychedelic experience and actually record data and information and actually use the tool to help remember and connect in with the medicine. So there's lots of different protocols being developed for VR. Obviously, it's a certain chunk of society loves technology in that way. It's hard for me to imagine being in a peak experience, putting on a VR headset, but there's many people that's absolutely the language that they speak. And
at our conference in September, we might very well have an exhibition of that VR for you guys to have a look at if you come to the conference. Melissa's going to set up her VR experience there, so hopefully we'll have a side room where you can have a little bit of a taste of it.
Absolutely. Yeah, we're aiming to have a one-day conference launch, just a small grassroots at harm reduction Victoria, about 80 tickets in person and then online as well, live stream, and that will be details of that to come in the next couple of weeks. So yeah, we'll be really excited to get everyone together and launch AMAPP officially.
Libby, just you asked about Indigenous practices and stuff. This is a really important area for us, and we are, part of the reason that Ernest is so important on our advisory is that he has a great network of Indigenous psychedelic therapists that I'm hoping to be able to bring into the fold and really focus on providing a culturally safe practice, culturally safe protocols. Huge big picture issue for me would be in the future to provide on-country treatment. But that's a whole nother conversation.
Any other questions? There's just some comments. Yes, there's certain organisations haven't released any position statements. I'm a social worker as well as a psychologist. I've been tirelessly advocating for a psychedelic social work interest group. Unfortunately, hasn't been allowed yet at ASSW. So there's still peak bodies that are either remaining silent or neutral or waiting. But I think it's really important from a multidisciplinary perspective, if you're attached to any organisations, to reach out, and because we actually do need leadership from everyone in this space, because it's a big shift in consciousness and healthcare. It's pretty massive, and we are actually going to need all those associations to have a voice for their members. So yeah, particularly any social workers in this space, encourage you to reach out, or PACFA as well, mentioned there. Any other questions about AMAPP at all, or how to become involved? I guess just mentioning we've got a policy committee, community outreach committee, the credentialing committee, as well as, I feel like there's one more. What am I missing?
We've essentially got a lot of scope for people
Education.
who want to be involved in policy creation, in especially fundraising is going to become really important for us now. We shoestringed together the website and the legal fees, and we're going to start taking membership fees now, which will help us, but we don't want to charge too much. It really is a matter of getting donations. So if anybody has any expertise in that area, I'd love you to make contact with us through the website. And it's really going to help this work.
Can I just ask a question about that particular issue? AMAPP has credentialing and advocacy in education as key directions. Has there been any discussion, and I'm obviously very new to this, but has there been any discussion in terms of the raising of resources and funding and the potential for perceptions of conflict of interest around, being the people who credential, who educate, and also generating a resource stream to support practice? And should there be some kind of process of creating a slightly hands-off approach to that part of AMAPP's activities?
Thanks, Ernest. I think you're right. I think it is a very difficult issue. To be clear, while we are credentialing, we're not educating. So we're not training PAT therapists, but we will be providing education as part of our services. That provision of education certainly falls under a not-for-profit umbrella. we've obviously got legal advice on this, and actually I just wrote a piece today for the lawyer to submit to the ATO, who will be very strict on not-for-profits. They're clamping down on not-for-profits. So I guess the answer to your question is we're going to find out quite soon whether our model as proposed and the constitution as written will allow for a not-for-profit organization, or whether we will have to split off and have a not-for-profit arm of the organization. I'm hoping that most of our work, which is advocacy and public education and clinician education and pushing the medicine, pushing these treatments for people who can't afford them, will get us over the line. But yeah, valid question.
If I can just come off the back of that, your question around conflict of interest, Ernst, we have a conflict of interest policy as well that we've developed, that we abide by, and we expect our members to abide by as well. So any undeclared conflicts of interest will not be viewed favourably by the organisation, and if they're deemed as breaching the code of conduct as well, there'll be repercussions there. So, we're trying to be transparent while we're offering, like many of our members have said tonight, the safe and efficacious practice of a new emerging medicine. So that's my input there.
And someone just mentioned about networking. So we're developing a membership portal, and I guess from a community outreach perspective, we want to grow this space. So obviously have different spaces in that. There might be perhaps therapists, psychiatrists, general space. Also, I'm very passionate about co-production and co-design, so people with lived experience. So even though it's a membership organisation for professionals in the field, I think we need to have a space for clients that are feeding back in data from co-production and co-design. So anyone that has those skills and has those interests, please contact me from the community outreach perspective, because again, we can't just have this structure if we're not actually tapping into directly to the people that are having these powerful substances. They need to have a really clear channel within the organisation.
I just want to make one thing clear, a little bit on the back of that, Lani, was that our code of conduct quite clearly states we work within the legal framework. None of our therapists are going to be allowed to practice illegally. So if you want to be credentialed with AMAPP, you can't be working outside of the law. What I would like to one day be able to get in our database of outcomes is actually underground work in our database. I would love for underground therapists, because there's no question that with the limited scope of psychedelics and all the hype around it, already those of you who have your ear to the ground of underground work have been getting huge amounts of interest from people desperate to have the therapy. So the underground work is going to explode. We've got no control over that. And nor can we control that. Certainly our members are not going to be involved in that. But I would love to collect data from that as well as part of our database, and we'll work on that in the future and see if there's a way that we can collect that data.
Yeah, and just seconding that, we're obviously clinically focused, legally focused, but also many of our members are passionate advocates for decriminalisation, and we will be partnering and working with people in the decriminalisation space from that harm reduction perspective, and also acknowledging obviously these medicines are legal in lineage in other countries as well. So we're holding those tensions as much as we can, and not prioritising or valuing one over the other. It's just that ours is the clinical legal context. Got another 5 or so minutes. Any other questions? Hopefully we've been clear. I guess the reason I wanted to have this webinar wasn't to wait until we had everything perfect and ready, because we need the community. We need you guys to feed back to us, to be critical, be reflective with us. And I wanted to get in sooner rather than later, just to introduce what we've been working on behind the scenes, and we'll probably have quarterly kind of updates where we can all meet and we can give you updates. But you can sign up obviously to AMAPP, even not as a member, just if you can find ways for us to plug in to letting you know what's happening as well. There's a board update each fortnight on the website, so you don't have to pay to read that. You can just watch if you want to take your time to feel into what we're doing. And yeah, any last minute questions?
No question. I just wanted to verbally thank you so much. I've been involved in the development of many things in my life, and I know how much time it takes and how much skill. And considering the significance and risks involved in what you're holding, I just want to, thank you.
Thanks, Libby. It's beautiful. Yeah. We need it. We need encouragement. It's straight to the heart. So thank you. Yeah.
Well, thank you all so much. Are there any other questions? Anybody shy to put up their hand and ask something that they felt was maybe a silly question? There are no silly questions.
Yeah, and I guess I'll just reiterate one more time. We're really passionate about, that it's not just psychiatrists and clinical psychologists or psychologists in the room. I think that doesn't represent the medicine. It doesn't represent diversity. It doesn't represent our clients. And we hope that with the credential framework that we're putting forward, we can balance having the prescriber, an ARPA registered professional, as well as other tiers of psychedelic practitioners that cover all those professions and diversity. And Indigenous elders, for example, shouldn't have to be ARPA registered to be in the room. That's not, appropriate and often realistic. So that's our main mission driving this, is that finally we can all work together and that power can be really neutralized, as we know that these medicines really deconstruct power. And if we have systems of power still replicating the same traumas that we've had, these medicines won't stabilize. So yeah, really hoping we get that all across the line. Nathan, did you want to say something there?
Yeah, just what you just said then. I'm traditionally a body worker, somatic experiencing breath worker. I've done the CPAT course. I guess I haven't had any major degrees like most people in the room. And I kind of wonder sometimes where I would fit in this kind of cohort. So I'm eagerly anticipating watching where someone like myself might be able to slide in and help somehow. So I get a little bit of hope and promise from what you guys are talking about. So I guess I'll hang around.
There will be a place. There is a place for you in our credentialing pathway.
Yeah. So the embodiment process and all this beautiful stuff that I'm learning, I can see how it works and it can slide in. But yeah, just waiting patiently. Thank you.
Because if the medical model doesn't rise to the challenge, people will just go to the underground. That's what they will do, and they don't need to. We've got all the skills. Now we've got the legislation coming. So this power struggle, needs to end. There's a way.
There will be a place in the credentialing pathway for, I'll just say sort of briefly, of the two therapists in the room, one has to have psychotherapy training, but the other one doesn't necessarily have to. So if you've got PAP training that meets up to the credentialing standard, you will be considered what's called possibly a psychedelic facilitator, and you will be the second therapist in the room.
But the lead, psychotherapists taking that real leadership with the psychotherapy, the whole prep, dose and integration, and then the prescriber, of course, and the medical team. But it would be incredible if we could open up that second space to, as I said, and particularly multidisciplinary spiritualities, people being able to have someone that's, it could be a rabbi that has training in psychedelics, or an Indigenous person, or a Catholic, being able to really personalize the space, be very transformative. They'll still have.
I think that's where there's real promise in culturally appropriate practices. We start getting spiritual leaders and community leaders doing PAT training that don't necessarily have to have psychotherapy background. That's where the real goodness comes up.
Awesome. Well, we can finish it there. I know everyone's working hard, end of a busy day, and I'll send out in the next week some slides and some info and bits and pieces to the network. But you can check out our website and jump on. And if you want to be part of a steering committee, and just so people don't freak out, you know, the steering committees, you can contribute at your own will. It can be reviewing a document, provide feedback when you've got time. It doesn't have to be this huge, massive commitment. We're all really busy, but there might be something that you particularly have a skill in that, you know, we really just need advice on. And yeah, so I'm the person that you can contact to kind of feel into what skills you have, what time you have, what's your vision, and how we can support that as well. Beautiful. Awesome. Well, I might
just a quick thank you to you, Lonnie, for moderating us so well and for putting this together. Again, you know, you're so super productive in getting things done, so we appreciate it.
You can thank high functioning ADHD for that. Got to channel that energy somewhere. Yeah, beautiful. Thanks, everyone. I might just get Lou and Matt and Ant just to hang back and we say a little night together. And
Thanks so much, everyone.
Thank you all.
Just turn it over.